It's really an honor to be here to speak with all of you on my favorite topic, clinical ultrasound in global health. And so just to kind of take the pulse of the audience, how many people have used ultrasound in their own hands to take care of patients anywhere? And then how many people have used ultrasound in a rural or underserved or international setting at all? Less people. Okay, so I have no financial conflicts with any of the content that is in the lecture. Much of the data that I'm going to present is from smaller journals. A lot of them are open access because we wanted, a lot of us who publish in this arena wanted the data to be available to our colleagues who work and live in low and middle income countries. I have verbal permission to show a lot of images of some of the clinicians that I've trained. And the ultrasound images that you're going to see aren't for teaching you ultrasound, but just to show you a picture or a moving video to give you a sense of the quality of what we're looking at when we're doing ultrasound. So also a warning, I'm in my 40s. This lecture starts out really abstract, but I promise I will bring it back. Okay, so here's the abstract. I'm going to tell you how I got interested in ultrasound, teaching in the US. We'll review some data in support of the use of ultrasound performed by clinicians, so non-radiologists, non-sonographers in high-income countries, and then what data is available for low or middle-income countries, and then how programs are implemented successfully, and we'll go over a few cases. There's a lot of definitions of entropy, but scientifically speaking, things lose energy available to do work over time. Philosophically speaking, the natural process of things is to fall apart, right? We know this about the human body and human health. Given enough time, it kind of falls apart. So in medicine, right, this is us. We're fighting entropy. We're fighting to put things back together that are falling apart. So this is me at Harborview. Actually, this is probably more like my intern at Harborview overnight. And that big rock is their patient with a K of 9 in by Gemini who missed dialysis because they couldn't get a ride, who was refusing IV access until they get a piece of hot buttered toast. And this is my real patient from 2 weeks ago. And so we fight entropy on the individual level. And what I loved about ultrasound first in the hands of clinicians was that it was a really effective tool to help us in these acute care scenarios, right? It helps us get that IV access while that lady is munching on her toast. It helps us diagnose tamponade in a patient who is hypotensive. It helps us look for hemoperitoneum in a patient with trauma at Harborview. So as time went on, my interest in ultrasound grew from its impact on individual care, and it helped me to see that I could have more influence broadly on larger healthcare systems if I introduced ultrasound services into those systems. So fairly soon into residency, I had the opportunity to spend months in Rwanda teaching ultrasound to general practitioners who had just graduated from medical school and were immediately thrust into being in charge of a district hospital. There was 9 of them, in charge of a hospital for 500,000 patients and 20 health centers that fed in, that were all run by nurses. So I realized in teaching them that in this realm, kind of out on the right side of this slide, if we can introduce ultrasound services, the power of that influence is really amplified. When we teach or introduce something new to strengthen a weaker health system that has maybe fallen apart because of a genocide or a disaster, or maybe it never really developed in the first place, when we improve education for providers and develop them as human resources for health, then it influences not only the individual patients, but also the health system. And so it helps kind of fight entropy across the spectrum. So that's how I got involved in ultrasound and interested in teaching. And so how does ultrasound fit into the big picture of global health? That seems like a small thing. Ultrasound's been recognized early on as an ideal imaging modality by the WHO. They published a manual of ultrasound, a how-to manual, in '95, and then again in 2011. And though it's not written as a point of care manual, there's actually not even a recognition of the point of care ultrasound approach. So it's written as a manual for radiologists or sonographers. The only mention of point of care users, clinicians who might pick up the probe and answer a quick yes or no question, for themselves is actually a warning in this manual in the foreword about the misuse of ultrasound if you have inadequate training. And so that's the big worry. Later, in 2012, the WHO did publish a district clinician's manual, clearly meant for clinicians. And in this, there's a section on the FAST exam, which is focused assessment with sonography and trauma, as well as how to diagnose a ruptured ectopic using handheld ultrasound. And so it's coming along. Many of the large NGOs, MSF, IMC, PIH, use ultrasound as part of their deployments for disasters and as part of their health system strengthening programs. So we're seeing more use, but the governing bodies haven't yet adopted this. More of a big picture perspective. So 2 decades ago, the UN set forth an agenda for encouraging humankind to eradicate poverty, illiteracy, hunger, and disease. And those were the 2000 Millennium Development Goals. Since then, they've expanded those goals to 17 goals, and those are the Sustainable Development Goals. And they're very broad-reaching. But number 3 is to improve human health. And we can see that within that, there's many sub-goals that could actually be boosted or helped with ultrasound. We can reduce global mortality for moms by using ultrasound to diagnose ectopic, which is the #1 killer of women in their first trimester. We can use it to identify placenta previa and who needs a C-section and shouldn't be allowed to deliver and then bleed to death. We use ultrasound every day at Harborview to diagnose who needs to go to the operating room very quickly after a motor vehicle collision. It speeds diagnosis and speeds time to operative care, which surely must help decreasing deaths from road traffic accidents. So within this, theoretically, there's a lot of room for ultrasound. Has anyone heard of the essential surgery movement? It is it is a movement to promote access to surgery as a public health strategy in resource-poor settings. It was started by an international collaboration to identify what are the most impactful surgical conditions on human health, such that addressing these topics, this is what they came up with, addressing these would offset 80% of all disease burden globally related to surgery. So this is where we can make an impact. And then the disease processes that are in italics are the ones that could be used, where ultrasound could be used to either make the diagnosis or streamline or help with the management plan. And you can see it's nearly all of them. And so there's a lot of opportunities here for more use of ultrasound as we go forward in global health. So the field of clinical ultrasound, or point-of-care ultrasound as we refer to it, is exponentially growing. We know this in emergency medicine, where we have ultrasound integrated as a mandatory part of the residency training across the US. And where we have specific fellowships in ultrasound. There is an internal medicine ultrasound fellowship in South Carolina. And so those programs, we might see more of those. And so given the lack of radiologists globally and the lack of sonography schools and medical specialty training in general, care providers in many low and middle income countries have adopted this point of care model wholeheartedly. And so within the US, we've seen integration of point-of-care ultrasound in residencies, not only in emergency medicine, into internal medicine, into general surgery. Here they have a whole curriculum for the second-year surgical residents, and then into critical care rotations. And it's also garnered the attention of a lot of patient safety advocates. The use of ultrasound to guide procedures makes them safer, such as central lines, thoracentesis, paracentesis. And so there's been a big push across a lot of governing bodies for us to use ultrasound in at least that way. And so governing bodies within emergency medicine have all published curricula and position statements for the use of ultrasound. The International Federation of Emergency Medicine, the African Federation of Emergency Medicine, and then the American College of Emergency Medicine. There are other specialties that are also doing the same. So this was published, I believe, this year from Canada. And so they recently published their recommended consensus curriculum for internists. And for internal medicine residency training. And so the US doesn't yet have a document like that. I really feel like we should build it here or spearhead it. But this is kind of the content of what the internal medicine residents across the US are really learning piecemeal sometimes and through dedicated curriculum other times within the US. And so we're really seeing a formalization of a lot of the training. So as we see this emerging use of point-of-care ultrasound in high-income countries, we're seeing new uses as well, new applications. We started with the FAST exam in trauma, how to figure out quickly if a trauma patient has blood in their belly. And so here's an example. Black is clear fluid or blood in this, and so this is somebody with a bunch of blood in their belly. And then pretty quickly after that, that was kind of developed in the 90s, we started adding in new applications for use in acute care. So ultrasound for pneumothorax turns out to be a really sensitive tool with sensitivities in the high 90s for detecting pneumos, much better than the supine portable chest x-rays we were using in our sick patients in the ER. Slowly, we've added in abdominal indications with yes/no questions. Are there gallstones or not? There are gallstones. And then now, when I first started doing ultrasound, we were always told air is the enemy. You cannot ultrasound the lungs. Just leave them alone. They're full of air. Doesn't work. And now we're finding that ultrasound is great for pneumonia. And so right now, our biggest challenge, I think, stateside, is there's a major knowledge gap of supervisory clinicians and what the trainees are doing. They're taking this literature and running with it. Hey, this is an amazing new tool. And they're showing these images to their attendings who aren't sure what's going on. And so there's a training gap there. And also there's a gap between rural providers and what's going on in urban academic medical centers. So we're seeing more access to machines, more scanning, reshaping of the diagnostic algorithms in academic centers with residents. And then it's very different than what's going on rurally in the US. So over the past several years, ultrasound machines have become more portable, more durable, and more affordable. We're down under $5,000 for beautiful quality machines. And so we've seen this technology spread far beyond the reaches of adequate training. So it's a critical time for dissemination of education and information to catch up with this technology. The literature supports the notion that ultrasound is also useful in low-income countries, the same way it supports its use in the States. But there's still a lot of room for large-scale studies on specific impact. And so one of the first questions that people ask is, what's the ultrasound going to be useful for? And everyone always thinks, well, obstetrics, of course, right? That's across the world, everyone thinks, is it a boy or a girl? That's literally the #1 indication that everyone thinks it's useful for. And so this is a review article from 2011 looking at 58 different articles that had to do with teaching ultrasound or performing ultrasound in a low-income country. And what we found is that abdominal indications and obstetric indications, not just gender identification, are the most common exam types. And so while these are the main exam types, there are a lot of opportunities and emerging uses based on what's killing people globally. So these are two graphs from 2012 published on the WHO website. This is what people die of in the world in low-income countries, and then on the right side of the screen, lower middle-income countries. And so in low-income countries, we see lower respiratory infections is still pretty much #1. HIV, TB, obstetric-related mortality is common. And as you get higher in income, more non-communicable diseases and cancers kind of creep in. But what's exciting about this graph is that there's a lot of opportunities for ultrasound to help in diagnosis. And so what I've added in here is that for each of these disease processes, there's an ultrasound exam that could be used for diagnosis. Now, pneumonia scans are fairly new, but turning out to be great for actual diagnosis of pneumonia. HIV is a laboratory diagnosis, AIDS is a clinical diagnosis, but the complications of HIV and AIDS, cardiomyopathy, nephropathy, DVT, these are all common and able to be diagnosed using ultrasound, and so on down the list. So in addition to where we think theoretically ultrasound might be useful, we're seeing more research on ultrasound to aid in the diagnosis of specific diseases like pneumonia in specific chief complaints This is a study I'm going to talk about later that we did in Haiti, looking at ultrasound and the use of the chief complaint of dyspnea. And then we're also seeing a lot of great data looking at the use of handheld ultrasound or portable ultrasound by nurse midwives, clinical officers, and non-doctors, because these are the folks, due to task shifting, who are actually in the wards taking care of patients. If there's 9 doctors for a district of 500,000 people, they're doing administration stuff or they're in the operating room, but they're not in the wards taking care of those patients usually. And so we're actually seeing some really good data that nurses who are trained, nurse midwives, and clinical officers can actually use this tool pretty effectively with proper training. So this is a review article from the last one called looking at the actual impact on patient management plans using ultrasound in low and middle income countries. And so some of these studies show a pretty wide range of change in management, 30% change in management after doing the ultrasound, and all the way up to in the 80s percent change in management. So really a lot of impact using ultrasound as an adjunct to the history and physical. This next one was published in 2016 by Patricia Henwood at Harvard, and she looked at 6 months of data from 3 different Rwandan hospitals that serve about a catchment area of 1 million people or so. And she trained a bunch of doctors to do point-of-care ultrasound in a training course that was about 2 weeks long. And she showed that as they performed their scan, they performed thousands of scans over this 6-month period in these 3 hospitals. And there was significant influence of ultrasound on patient disposition. Shall they go home? Shall they be admitted? Shall they be admitted to the intensive care unit? And which medications were given. I did a study in 2008, also in Rwanda, and what we found was that ultrasound most often influenced the plan to do a surgery or to cancel a planned surgery, specifically a C-section or a DNC or a thoraparenthesis. There's been a number of other studies that are specific, looking at focused echo and its use in low and middle countries to identify rheumatic valvular disease. So it's another kind of hot topic for research. Dr. Sotudania from cardiology here is training nurses in Nepal to do complete echoes screening for rheumatic valvular disease. And so there's data for ultrasound use, and there's emerging new applications. And then the next important question with any sort of global health intervention or endeavor is whether it's sustainable. And here's where we need a lot more information. The data has not yet caught up with the explosion of technology. This is a study published by colleagues from Harvard and Rwanda looking at the use of observed structured clinical exams. So it's kind of like the new way we're testing to see if people really know what they're doing with ultrasound. Because you can give them an image recognition test, you can ask them questions, but unless you see them scan and know that they're interpreting their results properly, it's really difficult to see if people have learned. And so she did this training course, Dr. Henwood, and then she looked at an OSCE after the completion of the training course and then 58 weeks later. And the average score went from 81%, pretty good, to 84%. And in that time, the clinicians had scanned almost daily. And so there was long-term retention. I can tell you anecdotally, I started teaching 1 to 2 courses a year in Rwanda in 2008. I've trained hundreds of doctors in ultrasound there. I no longer go teach. We did 2 training of trainers courses, and now those physicians have taken over completely the 2 courses a year, and they train 20 doctors at a time in 2-week courses, and it's all done locally. And so I'm invited to watch if I want, but it's pretty amazing. But we need more data to show that this is sustainable and that it's spreadable and scalable. So ultrasound's useful. Why hasn't it been used more or more easily adopted? So here's some results from a survey. It's kind of small, I apologize, that we published looking at the barriers to ultrasound adoption. We had responses from 38 different lower middle income countries. Most of the responses were from physicians. And these were the barriers that were listed. And when I first kind of started with this survey, I thought it would be machine failure or mechanical failure, but actually lack of ultrasound training is the #1 barrier that clinicians in these countries identified as why they can't use ultrasound. They actually have the equipment. And so Dr. Lacey Legrone, who's one of our senior surgical residents here at UW, on her research year, partnered with colleagues in Peru and other members of the Department of Global Health here to publish a review article of 41 different articles that they looked at where ultrasound was used in a global health setting in a lower middle income country setting. And she looked to see what people were doing for training and whether people were meeting the WHO standards for what it takes to be ultrasound trained. And so what she found was that in these articles, most people were actually not meeting the WHO standards. Now, these are standards that are set forth just by kind of expert opinion. There's no data that says after 250 abdominal scans, you are good to go. You'll never make a mistake. There's no data to say that after 250 obstetric scans, you're good. And so most people are not really meeting these requirements. And she found that the obstacles, again, were training, but more specifically, there's a lack of teachers. And there's a lack of time for clinicians living in a lower middle income country where their paycheck is going away immediately to actually go and pursue training. So since training is identified as the biggest barrier, there have been a few different types of programs and types of training models that people have tried. Again, there's a lack of sonography schools. 32 countries in the world still have no medical school, and many more than that have no sonography schools. There's only 19 residencies in radiology, all of sub-Saharan Africa, and many of those programs accept 1 or 2 physicians into their programs. So the whole thing that we do here with radiologists and sonographer, it just can't work in a lot of low and middle income countries. And so the point of care model and how to get people trained to use ultrasound in that way, it seems like kind of the only thing that we are able to do right now. So there's 2 types of trainings that are currently happening that are successful. Courses held on location in that doctor's own hospital with their own machine, where the trainer travels from somewhere, the expert comes in and does a 2-week course or a month-long course. Or there's centers of excellence. So the World Federation of Ultrasound and Medicine and Biology has set up a center of excellence in East Africa, and they can take people to come there. But again, that involves leaving their job, paying tuition, losing their income. And so it's tricky. So setting up an ultrasound program for success is a fairly detailed process. I'm still learning how to overcome a lot of barriers there, but I'm going to streamline some of the things that I've learned and as a strategy to implement any new technology in a low resource setting. So the first step that you need is a needs assessment. I can decide what I think would be useful, but that doesn't mean that that's what's actually going to be useful. So we need to determine the scope of the need, either through interviews or in person or through surveys, but meeting with hospital and district clinicians and ministries of health to figure out what are the patients dying of in this place. I found that it's really important to meet with local stakeholders from hospital administration. Are they willing to support an ultrasound program? That involves fixing the machine when it breaks. It involves buying gel, figuring out a secure place to store it. And then I've learned a lot about, finding out what's the power like. Rwanda is the lightning capital of the world. Who knew? A lot of these hospitals are high up on hills, are getting lightning surges. So the power grids are off and on all day long. A lot of the outlets in the hospital aren't grounded. So if everyone's getting shocked every time they're plugging in the ultrasound machine, they're not going to use it. So I've learned more about how to ground an outlet, how to build, carpentry-wise, a little secure cart, because none of the machines get donated with carts. Than I'm care to. But these are all really important pieces to set a program up for success. And then, in my opinion, some of the most impactful trainings are held on location in a rural place, where having an ultrasound service can really boost the capacity of a little rural district hospital, and it will prevent a lot of unnecessary transports. Before I introduced ultrasound in rural Rwanda, they would send a patient that they thought had tamponade in the back of a truck, an ambulance, over hours of a bumpy dirt road to go to the city to get an ultrasound that said, yep, they sure do, they've got tamponade, and then they'd put them back in, and then they'd come with a written report that just said something like tamponade, no details, right? And then they'd say, oh gosh, we have to put them back in so they can go to the cardiologist, the one, now there's 2 actually cardiologists in Rwanda. But, you know, at the time there was one, and they have to go see that person. So this is what we're dealing with. So when you add ultrasound into a place and you don't have to transfer those patients, at least just for a diagnostic study, it can really make an impact. And if you pair that with a hospital that can do an operation or give blood products, that is a big win. And so in thinking about who to train, these are some general providers. I usually train the providers that are actually in the wards taking care of patients. They could be nurses, they could be docs, they could be clinical officers, but the people that are actually doing the work, taking care of the patient, are who needs to know how to do this. And then I usually hold a separate training for all of their bosses who feel like they need to know what people in the wards are doing so that they can know what's happening. But I do usually do that separately. And so in general, there's a wide variety in the literature about ideal training length, a few days, several months. The jury is out. At Partners in Health, we do a 2 to 4 week course, full-time at a site. And that includes usually lectures to kind of teach theory, show images of normal and abnormal. It includes hands-on scanning sessions. This is a bunch of doctors learning from Dr. Meera Muruganandan, who's faculty at Boston Medical Center. She was the first fellow who completed that ultrasound and global health combined fellowship that we talked about. And they're all learning on their medical director, who said, sure, scan me, you know, practice. And then after they've gotten a little practice on each other and seen what healthy looks like, we go to the wards and we teach a clinical integration piece. And this is probably the most important, and it's what gets lost when you send clinicians out to a course. They take a course, they come back, and then they have no idea how to actually use the ultrasound in taking care of their patients. And so we often do after lunch, after big Rwandan lunch of beans and carbs and everyone's tired, we do a brainstorming session before we go to the wards, where we think about each chief complaint and what ultrasound scans might be useful. And then lastly, as far as a strategy for training ultrasound, a train the trainer model is super important. As I mentioned, we've done this in Rwanda, we've done this in Haiti, and it's been very successful. So for each ultrasound training I do, identify a couple doctors or nurses or clinical officers who are really enthusiastic about ultrasound. And then, and usually people who pick up ultrasound pretty quickly. And then we bring them next training, we bring them with us. We have them do a lecture and teach. And then we put them through a training of trainers course. And then we will shadow them as they do their first courses. We give them the lectures, the PowerPoints, and teach them the language of how to teach hands-on scanning. And in that way, we're building local capacity. So let's switch gears a little bit and think about the curriculum for point-of-care ultrasound in a low or middle-income country. So the warm colors on this map are the low and middle income countries. So as you can imagine, it's pretty impossible to think of one curriculum that would span all of these places. But that said, in general, there's a few disease processes that are the diseases of poverty, really, that are quite universal. So can anyone, this is the audience participation piece, can anyone think of something that people die of in a low income country? Like, think back to that little colorful rainbow map. What do ladies die of? Lower respiratory infections, diarrhea, childbirth, right? Postpartum hemorrhage or peripartum hemorrhage. Exactly. So what I found, when you introduce anything new that can have an immediate impact in saving lives, if you can have a save case or two where you use the ultrasound very quickly to save a life in front of people, it makes it very easily adopted. They go from thinking that this is a machine to help us identify whether this pregnancy is a boy or a girl to, oh my gosh, I can use this to help save a life in front of my face, and then they're hooked. And so these are kind of the big killers that we focus on and to build a curriculum around for each place. So causes of hemorrhage, ectopic is the #1 killer of women in the first trimester. Diarrhea, you don't need an ultrasound to diagnose diarrhea, but there's really a lot of emerging data for the use of ultrasound looking at the inferior vena cava. In kids, we can compare the diameter of the IVC to the aorta. If it's way, way, way smaller, they probably have clinically significant dehydration. And this has been shown to be a more sensitive tool than the WHO scale for dehydration, the Gorlick or the Parkin scale, which were both developed in North America. And so it's actually a pretty good tool for even that. And so the curriculum that I teach and that most of the kind of trainers that do this type of work teach is basically a modified version of the bedside ultrasound curriculum that we teach in emergency medicine, but more focused on obstetrics and more focused on tropical disease manifestations. It's really hard to teach all of this in 2 weeks. So we usually do, this would take about a month of full-time everyday shadowing with a small group of clinicians, maybe 5 or 6 for one trainer. But as you can see, these can have a pretty significant impact on a lot of the acute care that's happening in the wards. So I wanted to end with some cases to give you a sense of how ultrasound fits into patient care in a low or middle income country. So this case is from Lesotho. Has anyone been to Lesotho? Oh, wow. It's so beautiful there. I wanted to give you the context. So it's a population of about 2 million. 3/4 of the 2 million people live rurally with very little access to care. About 1/4 of the people that live in Lesotho have HIV. It's the 3rd highest prevalence in the world. And if you're a pregnant woman in Lesotho, 50% of those people carry a diagnosis of HIV. So half of pregnant mothers are HIV positive there. So it's a fairly sick population with very little access to care. So in 2007, Sonosite donated several old machines that they don't even sell anymore to Partners in Health in Lesotho, and they were kept in a box until the training because nobody wanted to wreck them. So 5 years later, circa 2012, we did an ultrasound training, dusted them off. They were still in perfect condition for nurses who run 7 mountain clinics that were refurbished by Partners in Health. And so the course had lectures where we brought the nurses, or at least one nurse from each clinic, to a central location to do lecture and practice, mainly focused around obstetric ultrasound, because that's what they're doing at a lot of these clinics is deliveries and trying to figure out who can deliver there or who would not be safe to deliver there. And then the course had some hands-on training. So this is a colleague of mine from Oakland teaching the nurses at this course. And so, as I mentioned, some of the most successful ultrasound trainings involve going to the actual site and teaching those nurses or doctors or clinical officers using their own machine. And so this is what we did in Lesotho. After we did the initial training course, we spent time at the 7 mountain clinics helping the nurses integrate the ultrasound into their training. And so Lesotho is a really mountainous country with very winding roads. It's very difficult to get around, large plateaus. And so the quickest way around is on a plane. And so this is a plane run by a nonprofit called MAF, Mission Aviation Foundation. This is the first time I was in a small plane in Africa. And my plane wasn't even working. And so this guy was like, I can fix this. And then this is my pilot looking not very excited about it. But eventually we got up, we did not crash, and we covered an area that would take 10 hours actually over in an hour. And so the pilots navigate by sight. They only fly Monday through Saturday, basically kind of banker's hours until the sun goes down, because after it goes down, they can't see anything. And then it's a Christian, like a faith-based organization, so they don't work on Sunday. But they do transport for doctors, nurses, and sick patients. And so they save lives every day that they work. And so this is an aerial view of Bubete Clinic, where this first case is from. And the patients come from all of the surrounding areas, usually by horse or by foot. The clinic is staffed by nurses. There's a visiting doctor who comes once every few weeks or so for a couple days to round on some of the sicker patients or give advice. They do deliveries there. They do TB and medication care. They have a little lying in for women to come a week or two before they deliver so that they don't have to walk while in labor for hours. And they treat a lot of infectious diseases. They have about 4 inpatient beds. And the clinic is completely solar powered. So the ultrasound machine that we were using was being charged off the grid. So this is the last patient of the day in the clinic. Oops, let me go back there. She's 32, she's in her first trimester, and she's having vaginal bleeding. She's tachycardic, she's got a tender belly. And so she had a lot of barriers to get there. Her husband wouldn't let her go for 3 days of being sick because he was afraid of the money that it would cost. He didn't know that Partners in Health had taken over the clinic and that it wouldn't cost anything. So when her sister arrived, saw her dying, brought her to the clinic on a horse. The This is one of the nurses who completed our training, and he said, gosh, I'm worried about an ectopic or a septic abortion. Scanned her, and then the plan before the ultrasound would have been transfer her at first light. I'm worried about an ectopic. But once he saw the screen, again, black is fluid or blood, and down there at the bottom of the screen, that black is a belly full of blood. And she has an empty uterus, which is that gray blob in the center of the screen. You'll have to believe me. This is a picture of a screen of a very old machine. And then she also had blood tracking all the way up into her right upper quadrant. So she was really sick. So the hemoglobin machine was broken, but she was pale. This is my nail beds next to her nail beds. She had like barely a drop of blood left. So the plan was, we need to transfer her to a place where she can get blood and where she can get operative care. And the plan of waiting till the morning, once you identify a life-threatening problem, doesn't happen. So we got an ambulance, which was the one car. And driving at night is really dangerous there. But the driver was really motivated knowing that he was saving a life. The cell service wasn't working. We were unable to call the receiving facility, and the car left without the patient's chart. So my nurse ran out, that's him in the white, to the nearest horse and gave the patient's chart. And he agreed to carry the chart to the driver. So the horse rider cuts the ambulance off at the next pass, gives them the chart, the patient gets to the hospital. The doctor doesn't believe this nurse's note saying she did an ultrasound. They don't have ultrasound there. A nurse can't do ultrasound. And does a cultocentesis. Does anyone remember that procedure? Yes, gnarly. So big needle into the vagina, sucked out a bunch of blood and said, oh gosh, she sure does have a ruptured ectopic. So he gives her blood products and says, this is a little dicey. I'm going to transfer her again and transfer her. She got an actual operation and did great. And so he never commented on the horse-related HIPAA violation that happened. But so an example of how ultrasound can be used. I'll do one more case from Rwanda, the land of 1,000 hills. And it's a country where they've truly adopted point-of-care ultrasound. In the last few years, the Ministry of Health has put ultrasound or several ultrasounds in each of the district hospitals all over the country. The former Minister of Health, Dr. Agnès, is actually speaking here at UW. She's in town on December 5th. And then there's a Bending the Arc screening, which is a movie about partners in health, on December 6th. But I highly recommend Dr. Agnès's talk. As the Minister of Health in Rwanda, she's done amazing, amazing things. And now she's chancellor of a new medical school there. And so this is the patient. She has dyspnea. She's walked very far, and she's tachycardic. So it doesn't matter if you're in Seattle or in rural Rwanda, when a patient arrives with dyspnea, your differential is pretty broad. So this is not obviously a comprehensive list, but here's some of the entities we're thinking of, right? Could this just be hematologic? Is this cardiac? Is this pulmonary? Is this an infectious disease process? Probably. And then here highlighted in yellow are a lot of the diseases that can be ultrasounded. And so acute decompensated heart failure, very easy to see using bedside focused cardiac ultrasound. Pneumothorax ultrasound's really highly sensitive for that. Again, pneumonia. And then signs of PE, such as a DVT or right heart strain, are seen. So here's our patient on exam. You may notice she's cachectic. You can see her ribs. And so we ordered the plain film. And so if it's the right time of day and the radiographer is present and the chemicals work and haven't been diluted wrongly and the machine works and the electricity is on, you might be able to get a film and you might be able to read it standing outside in the sun. And so this is her film. And she walked with this, which is amazing. So she has an enlarged cardiac silhouette. And so usually when I teach this case, I make people commit to whether they think this big cardiac silhouette is either, heart failure, where they think they want to give her Lasix, or they think, gosh, no, this is a pericardial effusion. I think she needs, actually fluids and treatment for that. So raise your hand if you think it's heart failure. Raise your hand if you think it's a big effusion. Okay, so what we teach is a focused cardiopulmonary ultrasound exam. So focused cardiac and focused pulmonary ultrasound exam to help answer this question so we don't do the wrong thing. And so the focused cardiac ultrasound exam incorporates looking for effusion, looking at the left ventricle to see grossly how is it functioning. We're not calculating ejection fraction. We're just looking to see, is this left ventricle squeezing at all or not? And then the focus pulmonary ultrasound exam looks for lung sliding, which is a sign that there's normal healthy lung and not a pneumothorax. We look for B lines, and I'll show you a quick image of that, which can suggest pulmonary edema or some sort of alveolar process. And using this can help to further assess what patients have. And so here's her bedside echo. You guys were right. So here's the heart swinging in a bunch of kind of what looks black on the screen is all actually just fluid around her heart. So she has a pretty whopping pericardial effusion. It's very common in developing countries to see echo findings of tamponade before actual clinical findings because these are so slow growing. Now, if this was a stab wound patient, this patient would be off to the OR and they'd be really sick. But so here's oops, there was an example. Let's see if I can do it of what we might see in tamponade, and the kind of free wall of the right ventricle at the top of the screen there. It looks like it's just kind of getting scalloped. It's getting squashed, and so that is an example of what happens when a high pressure situation develops in the pericardium and starts to cause a tamponade. TB pericardial effusions can sometimes have septations. It can be simple fluid, and they can be a lot like empyemas and a little bit hard to detect sometimes. But tuberculous pericarditis is the predominant cause of pericardial effusion in all of Southern Africa, and it's most often associated with HIV co-infection. So if she had heart failure, her scan might look like this. On the left side of the screen, you can see her heart. Her left ventricle is barely squeezing. On the right side of the screen, the top part is actually a lung scan, and all those things that look like flashlights or bright lights shining through darkness, those are called B lines, and they're an example of what it might look like if someone had excess lung water. And on the bottom of the screen on the right is the inferior vena cava, which is plump. It's that black kind of structure that looks tubular, and it should normally kind of quiver or change with respiration. And here it's just kind of chock full of fluid, and she's got a lot of volume overload. So this is affectionately known as the triple scan and is really sensitive for acute decompensated heart failure. There's some great data from the States for that. So we studied this protocol in Haiti as Mira's fellowship project. And we found that ultrasound, when taught to Haitian internists and general practitioners, when used in 117 patients that had undifferentiated dyspnea, was actually a really useful tool. It could change management in 20% of cases. It was not a prevalent study, but we did find that 40% of the patients had newly diagnosed heart failure. We had those cardiac ultrasound images reviewed by 2 cardiologists in Boston in a blinded fashion, and they found that the average presenting EF was 14%. So patients were pretty sick from their disease. We also found that the negative predictive value of a single normal-looking parasternal long axis view, which is what that view was that I kept showing you, was really predictive of no disease, so 93% negative predictive value. So if you were going to learn one type of ultrasound in internal medicine and one view only, that would be the view I would suggest. So she did great. She got some antibiotics because everyone gets antibiotics. And then she got an anti-TB regimen, and she also got started on steroids to prevent a constrictive pericarditis. So in the interest of time, I'm not going to talk to you about the FASH exam, which I love, but I'm happy to kind of chat after or do kind of separate education. But the FASH exam is a really hot topic. It's the way to diagnose extrapulmonary TB in patients with HIV co-infection. So if they have a normal chest X-ray, but you still suspect TB, there's actually really good emerging data over the last few years that doing a scan of their liver, ascites, and looking for lymph nodes in the abdomen is very, very predictive of TB. With a likelihood ratio in the 11-something range, and very specific also. So I think we're going to see lots of data kind of coming down the pike for that. And so I wanted to kind of fast forward to some future directions to let you know that whether we like it or not, ultrasound is going to be in the pockets of all clinicians very soon. The machines are getting more and more portable. The Butterfly Network, which I suggest you Google, has developed a new way to make ultrasound probes with the technology inside them, and they're selling them for less than $2,000, and they plug into the iPhone. So very, very soon, they're coming into people's pockets the way a stethoscope would. Other companies are working on using the same kind of similar software to facial recognition to do image recognition, so that you could wave the ultrasound like a tricorder and it could say, yeah, there's placenta previa. So I think in our careers, we're actually going to see quite a bit of change and use of ultrasound. One kind of other piece of exciting UW news is that we have 2 Philips Lumify machines that are at the Wish Center here. And in February, we're going to download some really interesting teleeducation software where your attending could be sitting in their office and looking at what you're scanning and looking at you and your hand, as long as they're on 3G or Wi-Fi. My fellow in Malawi could be scanning, and I could be looking at them from Seattle and helping them with their scans. So I think we're going to see some really cool stuff. This also is super exciting. Colleagues at UW, including Kennedy Hall, who's one of my colleagues in emergency medicine, working with physics and engineers, are working on a new kind of pulse wave ultrasound technique to do therapeutic ultrasound to move kidney stones. They're working on this project for NASA, but it's really going to revolutionize point-of-care ultrasound potentially into the therapeutic realm, which is really exciting. So right now they're just doing in vitro stuff and doing the IRB, but some really cool new things coming down the pike. So if you're interested in learning more, feel free to email me, or there's SonoGuide is a great free website. Matt Dawson and Mike Malin put out 2 free iBooks on iTunes that are big volumes, very detailed, with associated videos for point-of-care ultrasound. And then most of the departments are holding courses in WISH. And so I recommend getting involved. Ultrasound is coming, and so it would be really great to see more people well-trained. And so I choose to teach ultrasound because it's useful, translatable, and an easily teachable skill. And it boosts care capacity in limited resource settings. And so I appreciate your time and listening to me on this topic and allowing me to reflect on it. And so thanks so much for having me. I appreciate it. Dr. Satia.
Thank you for that really mind-blowing talk. The images that you presented and the stories that you told were really compelling. Two questions. I find it hard to wrap my mind around teaching ultrasound in 2 weeks. You mentioned that there was a 2-week course and there was a retention 81 to 84%. Who is providing the feedback on a daily basis when these newly trained clinicians are performing ultrasounds? That's number one. And number 2 is, how can a place like UW that has all of its tertiary resources more sensitive to types of radiology, how can sort of ultrasound compete with that?
Tell me the second question again.
It's more about if we teach ultrasound for internal medicine residents, I don't know how much utility it would have
in this kind of center. Got it. Okay. So the first question regarding kind of long-term follow-up and looking after the trainees after their 2-week course, it's definitely a challenge, and it's one that I've tried different things. Right now, what we do is we create a WhatsApp group. Do you guys know WhatsApp? It's an app, and so we can send images. We can do it's sort of like FaceTime, where we can do video. The trainees send each other cases. Hey, what do you think of this echo? And it creates a daily dialogue where people are actually thinking about ultrasound. We do refresher courses every 6 months or so, and those are really, really important. I'm available on my Gmail. I work nights, and so I'm actually awake when my colleagues in Africa are awake. And so we do a lot of kind of back and forth about cases or difficult images, which I think really helps. And I think as we see more teleeducation options, it will be much easier. But yeah, but I mean, having kind of that technology actually really helps. And then I think where with UW Medicine, kind of the second question was at a center like this, where we have sonography, you know, almost 24 hours a day, and we have radiology. What's the point of care ultrasound? And I think kind of the most major impact is probably in patient safety with procedural guidance. Even just avoiding unnecessary bowel puncture and a paracentesis, right? Avoiding puncturing the lung and needing a chest tube and a thoracentesis. And then central lines are so much safer. I think procedural guidance is really huge. And then in the emergency department and in the critical care units, or even getting a portable chest x-ray can take minutes that we might not have. I think in those two realms, getting really good at that focused cardiopulmonary ultrasound or the ultrasound of shock. How and why is your patient hypotensive? Do they need volume? Do they need pressors? Kind of those two types of exams, I think will be really critical, because you don't really need to know emergently if someone has hydronephrosis. You just don't. But you do need to know if they have tamponade right away. And, you know, come July, when the cardiology fellows are brand new and the, you know, echo techs are not around, it's going to be really important for us to be able to do that ourselves.